So just to anchor and set the stage here, yes, I am actually a retired professor. So I'm emeritus now, and I retired last year, and that's not something that tenured faculty do at a place like a Vanderbilt, ever. Like, you actually have to wheel them out of their offices into a nursing home. In fact, they actually have a program called RIP, Retirement Incentive Program, where they encourage you to quit at between age 63 and 67. I took it a little earlier because I actually believe that higher education shares a lot of the same ills and problems of the medical industry, the medical establishment. I'm actually working at an outline for a book where I want to actually pull back the veil and show the seamy underbelly of the business model as higher education to flip people out. Because I really do like launching bombs and pissing people off, and I would do that regularly at Vanderbilt. But one of the things that I did over my 20 years at Vanderbilt is every year I would assign a project to my healthcare MBA students. And I would challenge them to go out and they would have to shop for a medical service, didn't care what it was. They'd have to come back to class with a paper, tell me what the prices were and what the nature of that experience was. And obviously it was always fraught, and I started doing this in 2005. And it was always fraught with pain, drama, ridiculous experiences, can't get calls back. Oh, why would you want a price? All this kind of garbage. And then, 2010 rolls around, and I would use Keith Smith's Surgery Center of Oklahoma as the model that everybody should look to. And so just because this is a J. Keith event, I was here 8 years ago doing a keynote ballroom event in Oklahoma City. And I was just like, I want to reach out and meet this dude. And so I reached out to Keith, and he was the most beautiful person. He said, Larry, come on by. Let me give you a tour of Surgery Center of Oklahoma. If any of you haven't done this, you need to do this. And we went by, and afterwards we went out and had some very fine wine. And I said, yeah, I'm a libertarian. And Keith says, but are you an anarcho-libertarian? And then I go, oh, now this is a guy I want to hang out with. And we've had a great friendship since that time 8 years ago. But everything operates differently in a world where you're not worried about submitting insurance bills. I go in and ask Keith, I said, hey, what EHR are you using? Are you using Athena, whatnot? He says, what does a surgeon want? CST, continuous time treatment in a paper chart, and go. He says, I don't do that garbage. I'm not submitting bills. Everything about it's different. It was just so refreshing and so memorable. And so please, if you have the opportunity to go and spend a little time and check that out, I know that's part of the opportunity that everybody has. The title of the conference is Back to the Future, How the Past Can Be Indicative of the Future Solutions. Completely agree. And let me take you a bit back in the past and anchor on a number of important points. And so I'm in my late 50s, so this roughly covers my time horizon. Important points. When I was a kid, you paid a pediatrician when you took your child. The world back then was you paid everything out of pocket. And you know what? That's the way it should be, period, going forward. DPC, awesome. We love DPC. Reality is insurance is a very simple concept. You need insurance for high consequence, low probability events, full stop, that's it. What we've done is we've socialized America into this mindset that their income is going to get stolen by their employer and converted into prepaid medical care at exorbitant prices for stuff that nobody really wants anyways. We've lost our way. And so now, I take a lot of prescription drugs. Used to take a lot of prescription drugs. And that was my way of getting some measure of value back from the fact that my employer took $20,000 against my will and converted into prepaid medical care, and there's no way for me to get any of that back. Once the money leaves there, it's off into the ether. We had major medical. Does anybody remember the days of major medical? Okay, that is catastrophic insurance that we should have today. It was like you would pay the bill and then you submit the bill and you get reimbursed 80% of the bill. So Americans were paying out of their wallets and they had the catastrophic insurance. That is the end game. That's where we need to be. The question is, how can we get there? And that's what I want to talk to you a little bit about. Other important point is that societally, elderly lived with their families. So if you think about it, you go over to somebody's house and oh, there's Bulow. Send Bulow upstairs. We're having guests pull the plastic off the couches. We're entertaining. And the point is that because the elderly lived with their families, there was a very different connection between end of life and that conversation. If I walk into the ICU at Vanderbilt and I have two patients, one who came to that ICU from living with their adult children versus one, the family's flying in from California, hasn't seen mom in 3 years, very different conversations. The latter, we're dealing with guilt and we're basically addressing kind of the family issues. The former, we can have a much more rational conversation about what the right disposition is here. So there's been this devolution as a society. As a population, we were thinner. If you haven't seen the BRFSS slide build, it's mind-blowing to just watch the fattening of America evolve right there before your eyes. The other thing is that, I don't know that they even exist anymore, but I remember being hospitalized when I was a kid and had a TNA or whatnot. And I remember waking up in the bed and my parents were there and there were voices because I was in a ward room. That was the modal way that we used to deliver hospital care. People were all in individual kind of tents in a ward room. We don't do that at all anymore. I don't think I can find a ward room in Nashville, Tennessee, where I come from. Oh, we have to have private rooms for infection and all that kind of stuff. Well, that was affordable. I mean, at that point in time, you could pay up, but you were paying for the services yourself. And the delivery structure was designed to be compatible with providing affordable services when an individual is paying out of pocket. Now, the social expectations are, yes, I need to have a private room. Yes, anything that touches can be said is related to health or medical. Somebody else has got to pay for it. The insurer's got to pay for it. There's no individual accountability or responsibility for any of it. So we've really lost our way. So take a look at this. So I went and found an old hospital bill from Hartford Hospital in Hartford, Connecticut. This is a bill on the right for a baby delivery in 1960. Okay, now there's a number of noteworthy things here. There's no CPT codes, HCPCS codes, no codes, ICD-9, 10 codes, none of that. Mama was in there for 5 days. Okay? How many deliveries in the United States was mama in for 5 days anymore? No. But that's an intelligible bill. Total bill is $230. The phone was $1.05 of that. Remember, we used to charge for phones in hospitals. You can see that $25 of it was for anesthesia, which is a clear luxury item. We've been producing humans since the beginning of time without anesthesia, so we had a 10% surcharge for that. But it was $230. Now, just some little math. The median household income at that point was $5,600. So that was about 4.1% of the household income, median household income. Look at it today. Median household income today, roughly $77,000. Go out to Kaiser Family Foundation and try to find some prices for baby deliveries. You're lucky $18,000. To produce a baby is now 24% of the median household income. Is there any greater indictment of the medical establishment than we are impoverishing Americans just to produce the next round of Americans? Like, this is as clear as you can get. What if healthcare had grown at the rate of the median household income, that baby delivery would be $3,179. Can you buy a $3,000 baby delivery anywhere. No. The prices are all wrong. The infrastructure has been developed that is all wrong because it's been driven by an apparatus that's disconnected from all of us as individual folks who are buying goods and services. So where do I want to go with this? It is un-American to not show the price of a service. Period. As an economist and a free market guy, I love markets. I love markets. We have to have prices. It allows us to engage in trade-offs. And right now in healthcare, I can't engage in any trade-offs. It's a way that we coordinate production. It's a way we allocate goods and services to their most highly valued use. All these things are facilitated. Gains from trade happen. Specialization happens because of prices in the market. And healthcare has lost that. And they lost it starting in the 1960s, all the way through the HMO movement. The number one thing that destroyed the U.S. healthcare market, in my opinion, was the creation of the HMO Act and creation of HMOs, which fundamentally cleaved the connection between a price and what the individual was paying in the form of co-pays. We went to a world that was $5 copay, $10 copay to go see your doctor, thinking that would be a great thing. All that did is create the hurdle rate of, it's only got to be $5 for me to go see a doc. One, I've devalued the value of the physician's contribution, period, because now I think about it as a $5 or $10 experience, and I will consume medical care once I cross that threshold, rather than being a legitimate reflection on the value of that service. So to me, prices are central. So in 2019, I went and saw my primary care doc, Rich Hawk, and I throw him under the bus a lot in my things. And I love Rich, great guy. It's like, one is I have my annual upper respiratory infection that I get every winter. And I'm like, I send Rich an email, said, dude, can you just hook me up with the Z-Pack? And he goes, no, you got to come in and see me. I'm like, dude, come on. He says, and I then recognize, obviously, he doesn't get paid unless I come in and he does a 99214, right? So I go in and do the Z-Pack, and he says, while you're here, why don't you just stop down in the clinic and just get a chest x-ray? Let's just rule out a pneumonia. He knew I didn't have pneumonia. I knew I didn't have pneumonia. But while I'm here, just get a chest x-ray. So I said, fine, go down and get a chest x-ray. And then 4 weeks later, I get my bill from Vanderbilt University. That chest x-ray, flat plate and PA, simplest thing in the world. Charged $397. Net of contractual adjustments is $200. I have a deductible. I am paying $200. If Rich knew I was going to have to pay $200, he would have never ordered it. If I knew I was paying $200, I would have never taken it, right? And so I was pissed. And so I called up Vanderbilt and I said, your prices are wrong. And they go, what do you mean? I said, your prices are wrong. Because across the street on MD Save at Premier Radiology, 1 mile away, I can get that chest x-ray for $52 cash. Okay? So, and they say, well, no, it's, the contractual is replied. I said, guess what? I'm going to tell you, I know exactly how this plays out. I was on the board of a public hospital company for a while. I'm not going to pay the bill. You're going to send it early out collections. I'm going to ignore them. You're going to send it, then they're going to pass it late collections. I'm going to ignore them, and no money will ever come forward. Let me pay you $100. They laugh. They say, you do know how it goes, but we can't do this $100 thing. So I was angry and dissatisfied with my conversation there. So I went to the White House and I met with President Trump. And one of my best friends is this guy by the name of Art Laffer. And he's actually the chairman of the board of my company. And so because of my friendship with Art, go to the White House, have a conversation. I just made a very simple point to the president. I said, 18% of the U.S. economy is making purchase decisions every day not knowing the price. This is just un-American, full stop. Okay? And he asked me, a couple interesting questions. He says, Larry, how would the hospitals feel about this? And I said, they're not going to like it. He says, how are insurers going to feel about it? I says, they're not going to like it either. And I said, the fact that both counterparties to a transaction do not want this to be transparent says everything we need to know, right? So that led to this issue of price transparency and the executive order of June 24th that year. And coming to some of the things that Marty raised here a minute ago. So once the medical industrial complex heard that there were rumblings in the Trump administration about doing price transparency, they were none too pleased. And they started kind of advancing their own worldview and their own thoughts. No. We don't need to show like real price. We can show, let us just show averages, which are completely meaningless. So I started doing a bunch of analytics and research behind the scenes to steal the spine of the administration. And one of the most important things to quench that agenda was, in a world where you have 5 to 10x price spread, an average is completely meaningless. And so I was behind the scenes processing 835 electronic remittance data. I live in a world of big administrative claims data, and that's how I do my company. It's how I do my research. So I could actually see the electronic remittances on the 835 transactions that going back to hospitals in the country. I actually knew what their prices were. They were gagged. I couldn't produce them and show them, but I knew what they were. And so I wrote a paper that did two things. One is establish that the massive price variation across markets. It's like pulling up to a gas pump, filling your car up with gas and not knowing whether you're paying $2.50 a gallon or $12 a gallon till after you filled your tank. That's the magnitude of the spread here, both within hospitals, across payers, and within market across hospitals. So that was important. The second thing that gets back to something Marty raised is I partnered with MD Save. Have you ever heard of MD Save? So upfront cash prices, hospitals can put their services on there. So I got all of MD Save's cash transaction history data, and I matched it with the 835 electronic remittance data. And I said, what is the relationship between the cash prices and the contracted rates? And on average, the cash prices that were being offered by the facility voluntarily at the same facility, 40% cheaper cash price offered up front. Okay? So that was all part of stealing the spot of the administration to move us forward. And so here's a picture from that day. Marty was there too with this, but I need to get a picture with Keith. So you probably recognize Josh Umbert out there, Atlas MD. And I was there after I did my talk, and I see Keith across the room. I was like, oh my God, the Messiah is here at this momentous moment. And I had to get a picture with him and ran over and gave him a big hug as well. But where did this lead to? Legal challenges where we're upheld, summary judgment. It led to the transparency in both insurers, transparency in coverage, the tick data. And before that was the hospital price transparency on 300 shoppable services, 75 defined by CMS, all that rigmarole. And so it started the ball rolling. And I wanted to show you just from a paper I've got coming out here shortly, just for a very simple thing, an echocardiogram. Pretty basic garden variety vanilla stuff, right? The marginal cost of doing an echocardiogram is it anything? So I've put here a number of 4 different views on prices. One is the hospital prices that hospital disclosed, and that's the blue plus signs. The second is what is in the transparency and coverage data, the tick data that the payers had to drop. Those are the green plus signs. And has anybody here ever touched the transparency and coverage data, the machine readable files? So you guys are just not right, because like this is not something anybody should do voluntarily. Nested compressed JSONs that, you know, is about a petabyte if you put them all together. It's massive, and a bunch of it's wrong. But the tick data is in the green plus signs. Then, given I live in a world of claims data and I have the 835 electronic remittances for a lot of organizations, I go and say, what is the price that I see actually getting paid? Because right now we have this problem going on in America around price transparency, where I fear that I've replaced one form of opacity with another form of opacity. Because before they didn't want to show. Now they're showing it in this data, in the tick data, that is so complex and so convoluted by places, service, modifiers, whether it's professional, facility bills. To make sense of that, you've got all these organizations out there trying to process this data, and they're coming up with different numbers. Because there's a lot of curation that needs to be done. If you think about it, the payers are not structured to create this information in this format. So for every NPI, pediatrician, there's going to be a contracted rate for them doing a cabbage, because they take the entire fee schedule code and apply it to every doctor and blows up into this enormous data set that's completely convoluted, Byzantine, and unintelligible, and has lots of extraneous information and lots of unclear real information. And so I fear that we have this challenge now in the world of price transparency, where there's lots of people entering this market to produce this information and distribute it to payers, providers, employers, whatnot. But how do we know their numbers are right? Because none of us can easily look at these files and say, are the numbers right? So that's why I use the 835 data, because I have the gold standard. Money, actually, this flew from here to here based on this CPT code. Like, I'm looking at it. So those are in red, the red circles, and the yellow triangles. And what do you see? Well, I've got on the left, let's see, I've got Mount Sinai, and on the right I got Stanford. Now Stanford is always a complete whack job when it comes to pricing. But look at the scale on the bottom: 0 to 2,000, 0 to 8,000. So I'm looking in the triangles. Those are actually validated transactions that I see between Aetna, Anthem, United, and some other payers at a $6,000 price point for an echocardiogram. They're real. Like, I have claim lines, claim numbers. And then, but those are on the facility claim. What's very unclear for people to break apart is facility versus professional claim. So the hospitals, where the hospital prices they're reporting out there, the payers are reporting in the tick data most often prices that are associated with effectively professional services. And it really matters: site of service, professional, institutional, all of these things matter. And it's completely convoluted and confusing if you look at the raw data. But look at the price variation across payers, levels, and what's real. And there's lots of prices that are posted as contracted rates. But if nobody ever uses the contract, is it real? So that's why I care about what's actually going on here in terms of the real data. And so we have a mess on our hands here associated with that. When I ran a conference the first year after we did the price transparency, Keith was kind enough to come, and I had policy folks in Nashville and industry folks, and I put up on stage two friends of mine. One was director of managed care contracting for a large national healthcare system. The other person was director of provider contracting for Blue Cross Blue Shield of Tennessee. And I put them up on stage. I said, first, why are you guys such assholes? I mean, like, why did you fight this price transparency stuff the way you did? And the hospital guy made an interesting point. He says, Larry, you have to understand, my customer is Aetna, United, Cigna, Blue Cross. It's not the patients. So I don't think about price transparency for them. All I care about is my customer being the payer. Obviously, a huge problem. The second thing I did is I asked him, I said, okay, Jason, if I walked in with Marty's credit card, and I'd like to use Marty's credit card rather than mine, and I said, I'm going to pay cash today off of your contracted rates, what kind of discount would you give me to pay cash today? He said, we'd do 35% right off the bat. So think about all the friction, all the non-value added stuff that's going on in the middleman stack throughout this world that does nothing to create any value for any of us. The opportunity is massive. And so this isn't a sprint. This is a marathon. We spent 40 years destroying the price mechanism in U.S. healthcare and cleaving the connection between an individual pulling out a wallet and paying for medical care. It's not going to flip overnight. What's going on here, this group, this thought process is central to revising the narrative and putting us on the right path. And part of the way to think about price transparency is it's actually probably a fool's errand to actually worry about, can I get the price right for this CPT code, for this carrier, at this location and whatnot. It's a stupid way to contract, period. What we really need to do is make this so transparent that everybody understands this is crazy, and then providers can win by doing it simply, that is transacting in cash. So that to me is really part of the agenda. It's not just showing the contracted rate. It's highlighting the fact that the way we're contracting and paying for things is wrong, and there's a path to the promised land. And so that's, I think, a really important component of the price transparency. So as I think about, as I see the future is the past where we started the story. It is catastrophic major medical, which is not expensive. We could do that. And then a DPC membership model where we don't live in a world of filing 837 electronic remittance forms and coding and all of that apparatus that doesn't create any value for us and has led to the physicians going and being bought by health systems because they don't want to deal with the apparatus. My residents at Vanderbilt, I would have to convince them to actually go and do their residency. A bunch of them would just get so disenfranchised that they're living in a world that's not the world that they want to be, and they want to be healthcare providers. They want to have the patient relationship. They want to do that. And now their entire world is coding, billing, and stuff that is not rewarding to them. We've destroyed actually the practice of medicine that physicians were so gracious to dedicate their lives to. And there's a better model. And so growth of DPC is huge. And cash transactions is path to the promised land. I would sit there and talk to Rich, my primary care doctor, and say, Rich, I said, listen, can we just do a side deal? I want to pay you $2,000 a year just to do me. Like whenever I call you, just do me. And we don't worry about any of that other stuff. It says, because Rich, right now, you're producing 3 99214s an hour with effectively a contractual kind of receipt of probably about $650 an hour at Vanderbilt. I said, Rich, are you getting paid $1.2 million? That's simple, because all that apparatus creates no value for me. I said, there's an alternative. He just can't get his head around it. He's just like, I like seeing patients. I might not be busy enough. I said, listen, no, that's your choice. You could do whatever you want, but you would have a much more rewarding life, and I would have a much better experience, and you and I would have a lot more fun. And so the final most important thing here too, and I was asked this by President Trump when I made my initial opening remarks, is that if healthcare prices were not going up at the rate that they are, health insurance wouldn't be costing as much, and we would have more money in our paychecks to buy all other goods and services that we need to have to live our lives. The real wage growth in America over the last 40 years has been de minimis. Why? Because every year the U.S. healthcare industry steals all the productivity and real wage growth and converts it into prepaid healthcare in terms of the rising cost of health insurance. And that has to end. That is part of how we need to move next. So what do we need to do to get there? Well, one, I love Marty's comment about not-for-profit hospitals. So in policy initiatives, we got to get rid of not-for-profit hospitals. I actually did an analysis that I hope will resurface again, where I looked at what is the that cost to a county by having a not-for-profit hospital there, because they pay no property tax, they pay no sales tax, they pay no unemployment tax. And what are these academic medical centers doing? They're going and buying up all the real estate and taking off the tax rolls. So I can compute actually how much higher is the median residence property taxes, because they are subsidizing Vanderbilt University or Johns Hopkins University. So that's one thing. But the real challenge is we've got to change the game on employers' participation in the health insurance market, period. And to do that, we need to tax your health benefits, and we need to move to a world where we can create monster HSAs where people can save the money in a pre-tax form and encourage that kind of savings, because right now we live in a world of intergenerational wealth transfers. The elderly, Medicare folks, are being paid they're being subsidized by the 30-year-old working person. We need to actually be saving over the course of our lifetime. And so there's a very clear path on how to solve this. The question is, and the challenge is that so many individuals currently rely on maintaining the system exactly the way it is. And so the coalescing of the energy of this group to create an alternative that's value-laden, that everybody wants, that's how you change all those policy issues, by having this rise and say, oh, I want that. I don't want that health insurance. I want that. That's the win. So congratulations on everything you're doing, the commitment you all have made to put America on the right track. It's central to saving this country at some level. So thank you very much.